Hello, I'm Doug DeVries. Thank you for joining us today. I practice at Eye Care Associates of Nevada. It's a statewide co-management center.
And hello, I'm Paul Karpecki. I practice at the Cincinnati Eye Institute in Cincinnati, Ohio, and Edgewood, Kentucky, and I am the director of the Ocular Surface Disease Center. First of all, I want to welcome you to our webcast. I want to thank you for your time in joining us. Today we're going to try and go through some of the pertinent details related to managing ocular surface disease, and in particular dry eye. We'll take you through a little bit of understanding the demographics and the basis for it, and we'll go from there into a little bit of the predisposing factors, diagnostic tests, a series of treatments, as well as billing and coding, and then kind of tie all of that in together at the end. So to begin things, I want to start with just understanding a little bit about the impact of dry eye. The Beaver Dam study that came out a few years ago showed that over 14.4% of the population of patients over age 40 suffer from dry eye. And I think it's a highly underdiagnosed disease. I also believe that there is a significant, not only underreporting, but under-symptomatic addressing of the issue. There was a study by Chalmers a few years back that looked at this specifically and found that as they analyzed it, that a lot of the patients would rate what they felt their symptoms of dry eye were, and at the end of the exam, the eye care professional, the optometrist, would then rate what they felt the symptoms of the patient were. The surprising thing was that it was dramatically different. The patients all rated their severity as moderate to severe, very highly related overall, and the doctors, looking at these exact same patients, just based on their exams and their history, rated the patients as mild to moderate. So the first thing that came out of that was a very significant difference between how doctors look at this disease and the true impact that it has on patients' lives. Doug, do you find some of the same things and these studies that kind of manifest when you're examining patients?
Yeah, I do, Paul. I absolutely do. The impact that patients have, or the impact that patients feel with the symptoms, until I started actually testing those patients and asking them the questions and do further testing, I would go right past many of the subtle signs. The signs just aren't as severe as the symptoms that would lead to an earlier treatment.
You know, that's a great point. So many times I believe doctors do look at that and either treat when it's symptomatic, and there are so many factors that prevent that. The eye becomes neurotrophic after a period of time. That is, it loses the ability to sense, and so symptoms actually go down with the more severe dry eyes. There are times when we see the opposite as well in some of the early stages. And so I think it's quite important to look at that. And beyond that, there's many publications. In fact, there was a Jobson study referring to that actually showed patients found that the impact on their quality of life was extremely dramatic, to the point that they would actually give up years of life just to find symptomatic relief. So it was quite surprising. And to take that one step further, that study looked at pain thresholds and it analyzed every disease patients could have, from angina and cardiac problems all the way through to dry eye. And they found what was quite interesting is when they analyzed this on a pain threshold, that the severity of dry eye symptoms to patients was equivalent to that of angina or chest pain. So it was quite amazing for us to understand the impact it has on quality of life. And there are a lot of factors that kind of tie into it. Many of them obviously being multifactorial to this disease itself. Some you can't do anything about. Gender would be one example, or age. As the aging population gets a lot more dry eye. Females have about twice the incidence of dry eye to men. We believe that's hormonal related, not so much though estrogen and progesterone. In fact, to be fair, it's actually inverse to estrogen and progesterone. A women's health study that analyzed a series of women who were perimenopausal and on hormone replacement therapy found that they actually had a greater incidence of dry eye. And women who were on estrogen only had 7 times a greater incidence of dry eye who were on estrogen-only hormone replacement therapy. So it really showed us that it was more of the testosterone that played a role. Medical history would certainly play a role in terms of medications like antihistamines as well. Systemic workup, arthritis, diabetes, acne rosacea. There's so many conditions that contribute, even Graves' thyroid disease. Previous surgeries like LASIK. We know that there is probably a temporary dryness associated with a significant percentage of the patients who undergo LASIK. Begins with perhaps the goblet cell density being affected from the suction ring of the keratomes. and whether it's laser or microkeratome, it still has the suction. We also see that the neurotrophic effect probably is a very significant factor. May even be the lid movement over top of a changed ocular surface. But the point is, we see it in other procedures like LASIK, and certainly very important optometry, as well as contact lens wear, a very contributing factor, as well as playing a role in terms of patients wanting to get back into contact lenses. Doug, do any of these predisposing factors I went through stand out to you, or any ones that you kind of highlight in this regard?
Well, they do. Then the LASIK is one in particular. With the number of our population, over 7 million people having had laser refractive surgery now, that actually is a huge, what we say, opportunity from the standpoint of optometrists to treat it, because most of those patients are being seen in optometric practices. And as is the contact lens, when we take a look at the contact lens market, and while there are somewhere to 2 to 3 million new wearers every year, there's also 2 to 3 million dropout. And that is an area within optometric practices that really lend itself well to the treatment of dry eye.
You know, I agree with that. And I think another one that for me is extremely important, I think that we often overlook, and part of the reason we overlook it is there are new therapeutics, there are better forms of punctal occlusion in terms of the technologies, that we often overlook the environmental factor, knowing that we have other treatment modalities. And I believe that's critical, because if you could put punctal plugs in their eyes, you could put them on therapeutics directed at the disease, but if they've got a ceiling fan, they spend 8 hours on the computer, they, the blink rate goes down, they're a smoker, they have high intakes of caffeine, you're going to be spinning your wheels, not getting to the level that you'd like to in terms of the recovery or the patient expectation. So I think you really need to manage the environment. How long do they spend on the computer or reading? Are they a smoker? What level of caffeine intake? Small amounts are probably beneficial to dry eye tear secretion, but as far as large amounts, they become a diuretic. Patients who are on antihistamines, patients who take Premarin, which is the estrogen-only hormone replacement therapy, all of these factors contribute and can be adjusted and alleviated to some degree, so that then you can focus on the disease with some of the newer options, such as punctal occlusion, which we were revisiting quite a bit, and even therapeutics.
What may seem obvious to us as practitioners is not obvious to a patient at all. Often that environmental situation that they place themselves in and day out, just by altering, bringing them to the attention. And that's where education plays such a big role in discussing the environment as well as other conditions of dry eye with the patient.
You know, that's a really good point, Doug, because I remember a patient I'd seen earlier this year who had chronic inferior staining, and went ahead and tried to treat that with all the typical options. Put her on a corticosteroid and cyclosporin, and it would kind of improve, and then I plugged her and I'd get great improvement, but it kept coming back. And I couldn't understand after 6 months of that combination of therapeutics with punctal plugs has worked so well for me. We tried all these things, and finally I looked and asked her about her computer use. She said she spends about 8 to 9 hours a day on the computer, and it turned out that about a year ago, because her desk got so cluttered, she actually took the monitor and they had a shelf built about a foot above so she could work more on the desk and look upwards. So she was spending the upwards of 8 hours looking in this direction. And what was interesting is finally when I realized that, we had her bring the monitor to just below eye level, and on her 1 month follow-up, it all cleared up. So the therapeutics and the punctal plugs did the job, but if you didn't manage the environmental factor like you just said, we never really get the resolution that we needed. So I think that's very important to look at that. I also think that punctal occlusion plays a significant role. I feel like we've gone away from punctal occlusion in the last few years as far as management options, and what is unique is I've actually found that I've actually been doing more punctal occlusion in the last 6 months. I just find that we can now understand the benefits of first treating the disease itself, which could be the combinations of the corticosteroids, the cyclosporins, good artificial tears that we have now. But as far as then elevating that quality of tear, that is another essential factor. I find, you mentioned LASIK, I find in LASIK patients I quickly go to punctal occlusion. I believe it's perhaps the most effective treatment option that I utilize. But I also find that in the non-refractive patient, the patient who just has dry eye, perimenopausals we talked about, or environmental factors that are alleviated, that once I can manage the quality of the tears, the most effective thing I can do for their symptoms and for the patient really responding to the care is punctal occlusion. Your thoughts in the area of punctal occlusion? Do you agree that we may have gone away from it, and that's unfortunate when you look at patient care and the impact it has on that? And number two, what do you see as the importance of punctal occlusion, Doug?
Well, I do agree that we've gone away from punctal occlusion in a lot of instances. We're not addressing the dry eye soon enough, and then we're dealing with the quality of tear and then quantity of tear. And I always describe to my patients that first I'm going to improve the quality of tear, then I'm immediately going to improve the quantity of tear with a punctal plug. And they understand that concept. It really is quite easy. I tell them it's like putting a stopper in the sink. We're going to back some tears up. But first we need to improve the quality. If we were to address it sooner, say in early contact lens intolerant, or just seeing decrease in wearing time, decrease in comfort, if we were to address it a little sooner with that punctal occlusion, we may not need to go to the extremes. We might be able to keep that quality, because we know it's a cycle that starts. You know, as you get a decreased quantity, then you get a decreased quality.
I think that's a great point. And I think, you know, that the value there is both to the patient and to the practitioner. The importance is in areas I've found where I have corneal staining or conjunctival staining with lissamine green, and we're going to talk much more about diagnostics. Sometimes that's the step I need to completely alleviate it, is to elevate the tears. And I believe it's a very important factor. In fact, I think punctal occlusion is warranted now more than ever. You know, perhaps when we didn't have good treatment options, which is way back in the past, we then would occlude an eye, and then the issue there would be that the tears, although they were elevated and that helped to some degree, weren't actually treated. So if ever there was a time when punctal occlusion really has an impact, it's now because of the therapeutics, and I think that's extremely important. I also believe that for the doctor there's some great benefit. One, it really elevates the practice to the next level. It looks very therapeutic, almost surgical to some degree in regards to the ability to set up the tray, to modify the patient from a treatment would be a better term, perhaps, modality. And I like that because the patients respect that as well. They know that you're willing to go to the next step to try and take care of this. There's, you know, we'll talk about this later, but the informed consent process and all of that, and that you're really trying to direct whatever you can to their needs. And so beyond that, another area that I know Doug will focus on is the billing and coding, which I believe is also important to the practitioner because it allows us to continue to practice at such a high level.
Well, I do believe that using the punctal occlusion really is part of comprehensive treatment. If you're going to look at all aspects of environment, at medications, really analyze that case history, start the therapeutic treatment as well, I mean, it really is part of comprehensive. I will describe to every dry eye patient that dry eye really is like a rock being close to a cliff, and all these little trigger factors can push that rock closer, and as it gets to the edge of that cliff, it will start this cascade, which is that inflammatory cascade. And we're looking as practitioners for as many of those trigger factors to put that rock back up on that cliff. And I think when we're dealing with quantity of tears, that's what the punctal occlusion does so well.
I agree, Doug. I think now more than ever, there's benefit to punctal occlusion. Years ago, when we had fewer options of treating the actual tears themselves and the underlying cause of dry eyes, such as, you know, with the cyclosporin and the corticosteroids and some of the newer modalities, including oral doxycycline, for example, we did punctal occlusion, and it was very effective, but yet it elevated whatever tears we had. Now we're able to treat the tears and then elevate that quality of tear. So I think now more than ever we should be concentrating on punctal occlusion, not the opposite. In fact, I think the other great benefit beyond that is to the patient. One, like you said, it really does allow the patient to feel like you're addressing the needs. They understand the stopper in the sink. They understand the benefit to doing that. But also the benefit to the doctor is substantial. One, it raises the elevation of the perception of the practice. You know, there's an informed consent process. You go through this little procedure of punctal occlusion. You're able to explain it and teach them. I do think it gives a higher profile to the practice. And beyond that, something else we're going to talk about a little bit later is related to billing and coding. And I think that also has great benefit and allows the doctor to continue to practice at this level. So I think not only is there a benefit to the patient, I also think there's a great benefit to the practitioner in being involved at the highest level of care of these patients. That concludes this first section of our 5 modules. Thank you for joining us.